Good morning, everybody. Welcome to the first webinar in the Inside ABSAT series for semester 2 of 2022. It's lovely to have so many back who've already jumped in and joined us. Some familiar names there who've come along to hear what will be, I think, a very excellent presentation, very timely insights into things now that we've had these types of options for treatment available for a few years here in Australia. Before I go any further, I'd like to acknowledge the traditional owners of the land. I'm coming to you here this morning, the Insight office, which is in Liachen in Brisbane, to acknowledge past elders, past, present, and emerging, and also to extend that respect and acknowledgement to any of our Aboriginal and Torres Strait Islanders peoples who are in the webinar today. So just to let you know that in a few moments' time, I'll have the privilege to hand over to Dr. Simon Clay, who is a postdoctoral research fellow with good friends at NDARC, which is part of the University of New South Wales, and NDARC is the National Drug and Alcohol Research Centre. So very much looking forward to your presentation for us today, Simon. How we'll run things, for those of you who are familiar with Inside ABSAT webinars, this won't be news to you, but what we'll be doing is handing over to Simon, and then any questions, queries, doubtful points that you have, feel free to use the chat function to be able to post those. And then towards the end of the session this morning, we'll have enough time for being able to put some of those things to Simon for his responses. So that's how we'll run that. Just in case anyone has to leave early, I'll say this again at the end. We will not be having a webinar next week because it's a public holiday here in Brisbane and the Southeast Queensland region. So there won't be a webinar this time next week, but we'll be back on the 17th, and I'll talk more about that at the end. Great. Well, if we're all ready to go, I'll hand over to you, Simon. Welcome.
Hi, thanks so much for having me. It's an absolute pleasure to be here. Today I'm going to be talking about a study conducted last year / earlier this year on buprenorphine, this new treatment for opioid dependence, and why some people decide to discontinue. So I'd like to give a special thanks to Michael Christmas, Chris Henderson, Jeremy Haler, Chris Guff, Michael McDonough, Ian Richards, Tamika Moo, Sione Crawford, and Anne Barton. You were instrumental and so invaluable to putting this study together. So I'm really quite thankful for all of you. So buprenorphine came in Australia in 2001, and it was available in sublingual form. But in the last couple of years, the depot version, long-acting version, became available. And it was enthusiastically embraced by clinicians, particularly during the time of COVID, because it was longer acting, it meant less contact with the healthcare system and healthcare workers, which A, reduced the stress that they were under, and B, it was also more COVID safe. It also made it a more viable option for those in rural and remote areas, because it meant that they would have to travel into pharmacies and clinics that did offer opioid dependence therapy, and they could just stay at home for a month and then come in and do monthly trips. It encourages retention and abstinence because it is long lasting. It did help people remain abstinent for a longer period of time. And as such, people tended to stay on it for longer. And there's not a lot of risk of diversion because it's inside the body. So because it is quite recent, there's very, very little qualitative research that explores the experience of depot buprenorphine. At the moment, I've only found 5 studies that do explore this. There is a substantial amount of qualitative research on depot buprenorphine, But most of it is focused on, if you were to have this, what appeals about it, what doesn't? And so it's very prospective, and it's about patients' thoughts and concerns about the treatment. So that's why this study was really important, because we wanted to explore not only what it was like to have this treatment, but why some people decide to discontinue, because clinicians were so excited about this new treatment. So the research on consumer perspectives on buprenorphine was pretty encouraging. People seemed to really like it. There was a high level of interest and a great willingness to try. Prospective patients spoke about how it would give them a greater freedom to travel, because they weren't bound to go into the pharmacy or the chemist every day or every few days. It would enable them to get stable employment as a result and spend more time with their families. So it would enrich their lives in that way. It would help them to pursue abstinence and circumvent the problem of forgetting daily doses or being unable to get your daily dose. The long-acting nature also helped for treatment adherence, because you didn't have to go in every day or a few times a week. You didn't have that burden. And so it made it easier to stay on treatment and to continue on. It also reduces the time and financial costs of treatment. Receiving buprenorphine generally is cheaper, although that varies between state to state, but because it's done at clinics, there typically isn't the dispensing fee that happens at pharmacies. And of course, if you're going for treatment less, then it means that you're spending less time doing treatment. People also spoke about how it's more discreet, not having to line up to receive methadone, not having to go to a clinic as much and potentially be seen by people who you might not want to be seen by. And so that really appealed, the greater sense of anonymity that came with it. And as a result, less exposure to stigma. And that was a really, really big factor in a lot of this prospective qualitative research. So the qualitative research that did focus on people's experience on buprenorphine kind of confirmed a lot of this, but did add some nuance. So people did talk about some of the unpleasant side effects, which made treatment retention more difficult. In the studies that I've read, there weren't a lot of people who said that the side effects were so unpleasant that they discontinued. But there was this balancing act of, this is happening, but I really want to stay on this, but it's still something that I'm struggling with at the moment. The participants also spoke about no longer having the option to use opioids on top of treatment, and having that choice taken away, in a way, reduced their sense of agency and became a point of frustration for some people. And also feeling isolated from the reduced contact with services. Going into the pharmacy, going into the clinic every few days, you can have a quick debrief and a check-in with your regular clinician or healthcare worker. And that provided a really valuable sense of a social interaction and social connection for people who were feeling quite isolated, and also a way of debriefing and just sharing what you're going through. And if you do need help, it does give you an opportunity to voice that and to seek that out more easily. But the treatment freedom was also circumscribed by the long duration. So some people were concerned about how if you do take a monthly dose, then you're locked in for a month. If you don't like it, you've still got like another 3 weeks to ride out before you can change to a different form of treatment. And that did concern some. And there were also concerns about how to discontinue. People didn't know. People were unsure about what that process looked like. And so that was a point of concern for some people. So with our study, We conducted 40 interviews, which were carried out between November of last year and January of this year. 19 of the participants had discontinued or were in the process of discontinuing at the time of the interview, and 21 were on depot buprenorphine and were planning to continue. So the participants who were on depot buprenorphine, 16, there are two formulations of the drug. One is Buvidal and one is Sublocade. 16 were on Buvidal and 6 were on Sublocade, and the average time that people had been on it was 13 months. 6 were from Queensland, 5 were from ACT, 4 from Victoria, 3 from South Australia, 2 from WA, and 1 from New South Wales. There were 13 men, 8 women, and the average age was 44 years old. The participants who had discontinued or were in the process of discontinuing, 17 were on Buvidal and 1 was on Sublocade and 1 was unsure. He was an interesting one. We'll get to him a little bit later. And the average time that they had spent was 10 months. And there were 13 men, 5 women, and the average age was 41 years. So the cohort was primarily middle-aged or around there. 5 were from the ACT, 5 were from WA, 4 were from New South Wales, 2 from Queensland, 2 from Victoria, and 1 from South Australia. So participants generally had a combination of reasons and experiences that motivated them to discontinue. It wasn't a single thing, but more like a constellation of things that overlapped and came together in complicated and dynamic ways. So there are 18 major themes and findings that arose from the data. So some people decided to discontinue and either transition onto methadone or to discontinue all treatment because they wanted to use opioids again. They spoke about how they wanted to use as a coping mechanism because they were facing one or more issues in their life that they found quite overwhelming. And so opioids enabled them to deal with this and to care for themselves. And it was often spoken about as a temporary thing. I just want to use opioids just for a little bit while I get through this, while I manage this divorce, while I manage my son living at home and we have these tensions. And so by discontinuing depot and either moving to a different form of opioid agonist therapy or stopping pharmacotherapy altogether, these participants were trying to find a different way of taking control of their life and a new way of managing their health in the best possible way in relation to their circumstances. So I've got a participant here, Sarah, who said, I just had a few too many stresses in my life. I just wanted to have a dabble every now and then. I've been going through a bit of stress with my depression, like I'm back on the methadone program. I just thought that this was the best thing for me to do at this point. I would definitely look into doing depot buprenorphine treatment again. Interestingly, the majority of these participants said that they planned on starting depot again once their life got a lot more stable because they did find it pretty good and pretty unproblematic. So the second finding was a lot of people spoke about the sense of withdrawal when they either started or as it continued on or cropping up after they'd been on it for a while. Sometimes these symptoms were quite mild and only lasted for a few hours, whereas for others, they spoke about how it would last for 2 to 3 months and were really, really quite difficult to manage. The participants who had milder withdrawal symptoms tended to persevere through it and were quite happy to stay on treatment, but those who had more severe withdrawals, this was enough for them to want to get off. Interestingly, there were a couple of participants who experienced withdrawal symptoms when they discontinued depot, with some requiring benzodiazepine to help quell the severity of their symptoms during this period. So Peter, who I've got a quote here, he experienced withdrawal for a week before getting a second dose, and decided to discontinue because the symptoms simply didn't go away. And this was reason enough for him to discontinue because he also felt that his opioid dependence wasn't severe enough to work through this withdrawal. And he says, it was probably like a week after going back into a withdrawal state, I went back in there into the clinic and was just like, it's not working, it's done absolutely nothing. And yeah, that's when I had the second one. I just didn't have much care for it as well. Like I didn't feel like I had that much problem. Like obviously I did, but yeah, just in my head, it didn't feel like something that I needed to change. So after that second one and almost going through the exact same thing, I just thought, I'll stuff it. I'm just going to go full off it, just go cold turkey. Interestingly, with Peter, he was told that he had received a monthly dose, but we suspect that he might have actually received a weekly dose because he said it was working fine and then he went into withdrawal. And so there was potentially some miscommunication, and he did speak about difficulty engaging with the clinic that he went to. Beth spoke about how she felt like she had hit a wall of straightness at like 200 miles an hour. She was the participant who said that she felt like she had gone into withdrawal for 2 to 3 months. And she said, my body really grabbed hold of it. I was so scared. People were like, maybe you just need another shot and you'll be sweet. And I was like, I don't want to reschedule. So I wouldn't have another one. There was no way I was having another one. Thinking about this in relation to opioid agonist therapy and talking to some of the clinicians, one of the clinicians I spoke to said, because methadone does dull the senses and gives you, tends to blunt how people feel, going on buprenorphine and depo-buprenorphine, people all tend to sense a greater clarity. And sometimes this is perceived as a sense of withdrawal and can be quite shocking and jarring for some people. So that's potentially what's going on here. But I've also read in other documentation on depo-buprenorphine that sometimes sense of withdrawal can go for a few months. So not quite sure what's going on here, but it was really interesting that she experienced withdrawal symptoms for such a long period of time. So many participants experienced unpleasant side effects or unexpected side effects, which either began immediately after the first dose or emerged over the course of their treatment and ranged from being manageable to overwhelming. The depot exacerbated participant Oliver and Cassandra's chronic pain conditions, Deborah and Lucas. They developed chronic constipation from the treatment, which they had been treating with ongoing laxatives, which did give them some concern. Evelyn and Fred, they both began to experience major sleep disturbances and were unable to sleep through the night whilst on the treatment. And Chloe developed chronic pain in her arms after starting the treatment, which varied in intensity. And some of them experienced an exacerbation of mental health conditions, and that they, after starting this treatment, felt a deep sense of something's not right, and that the treatment that they had previously been on or the sense of balance that they had been thrown off track. So Steph here manages bipolar, and she spoke about how one of the people at my clinic said, I just need to present an emergency, which wasn't going to be acceptable. She said after she received her first shot that she entered a manic state. And she said at the start it was fine. I was getting a lot of stuff done, but I just wasn't sleeping. And it got to about 3 days and I thought, I need to address this. And so she went to the clinic. And she said, I remember thinking, I just have to write it out. It's part of the side effects. Anyway, they didn't believe me because I have a mental health issue. I didn't feel heard at all or listened to. I saw another doctor and he adamantly refused to believe it was to do with the Buvidal. And since I've been off it, it's all completely stopped. She spoke about the intense frustration that she felt presenting to her clinic saying, these symptoms started after I received my shot. I can feel that this is connected and I need some help for this. And the doctor's saying and the psychiatrist saying, well, there's no clinical evidence for this, so it can't be true. So go to emergency, you're clearly having a bipolar manic episode that is disconnected from this, we can't help you. Andrew also spoke about how he said, my mental health was suffering too much because of the restrictions of other medications I could go on. My GP said, I can't treat you while you were being seen by this team, the alcohol and drug service he was seeing. And I literally said, can you wait 1 minute? And I called up my clinic and I literally quit in a minute phone call with them and they wished me the best of luck. He was experiencing significant depression and social anxiety and was quite overwhelmed by this. And he had gone to his doctor he had been on Valium and Xanax for a while and had found it really beneficial. And his doctor said, I can't give you any prescriptions for this while you're on depot buprenorphine because of the interactions. So I can either treat you for your mental health or I can treat you for your opioid dependence, but I can't treat you for both. And on the surface, that ultimatum does sound quite problematic, but Andrew also spoke about how he did have a very deep and trusting relationship with his GP and that he had been seeing him for a long time and did have a deep sense of trust. And at the time, his cravings for opioids felt pretty in check. And so there was a sense of comfort in discontinuing, but yeah, this sense of having to choose was an interesting finding. Yeah, so these are some more of the adverse side effects that I was speaking about. So when these people approached their clinic, they were largely met with indifference or told that their symptoms were unrelated to the depot, similar to the participants that I just mentioned. So Chloe described her experience with the clinic nurse about the chronic pain that developed in her arm shortly after getting her first injection. She said, I spoke to my nurse, who is my case manager as well, that my arms have been aching a little. It started with a burning sensation in my elbow, then it started being an ache on one arm, now it's transferred to the other arm. I asked him and he said, no, it has nothing to do with Buvidal. And I said, well, you don't actually know this, do you really? And he said, no, it wouldn't do that. And I said, that's interesting because it only started happening in the last 4 to 5 months. And this wasn't uncommon, and this was a major source of frustration among the participants, that they were going to their clinician and saying, this is really bothering me, and it is connected, and clinicians saying, I don't know what to do in this situation. I'm not sure what the right way of going about doing this is. And I think you either need to write this out or take this and try and see if it helps, or discontinue. And a lot of participants found that to be quite an unsatisfactory answer. So one of the major motivating factors for some participants to discontinue was that they found it simply didn't help curb their cravings or prevent withdrawal symptoms. So for some, the treatment was ineffective from the start and just they never felt like it worked, whereas others saw a reduced efficacy over time until it just had no impact on their cravings or withdrawal symptoms. Andrew here says, it just didn't help at all. But when I went through the first booster injection and then on the third one, it still wasn't doing anything. So I just kind of stopped, and I was already finding withdrawal symptoms and it just wasn't helping or holding me. Other participants found that their dosage was wearing off early, prompting some to discontinue. And when they approached their clinician about their dose running out early, they were often offered a booster shot or some sublingual Suboxone to tide them over until their next scheduled appointment. However, like I said, there were others who were told to just deal with it until their next injection. The participants who decided to discontinue because their dose was running out described passing through a kind of threshold. Putting in the effort in persevering with the treatment was greater than swapping to a different form of OAT or dropping out altogether. So sometimes this effort was in relation to working with their clinic, particularly when the participant had poor experiences with their clinic and healthcare team, and that effort was too much to keep going. While other times it was the energy to continue with the medication itself. So Peter here says, I only got 2 doses and I think it was a monthly one or something, like I mentioned before. You were supposed to get one every month, but the first one I got it felt like it only went for 3 to 5 days. And so I went in and got a weekly one and then stopped after that. This was a really interesting finding. There were 2 participants who had been told by friends that the depot would feel like a month-long hit of heroin. And when this feeling did not eventuate, they decided to discontinue. In the case of Lucas, it was his dealer who told him to go on buprenorphine. He said, my dealer discovered it. I'd never heard of it before, and he told me, get off methadone first, which I did. And I kept using heroin. And then he told me about the bup strip. He said, you'll get more wrecked off that probably than the gear that I'm selling you at the moment, which attracted me, honestly, the thought of getting high off medicine. My dealer told me about it, which is sort of weird because, he still wants me to be his customer as well. And he was using Buvidal and using heroin as well. Which I found really interesting because he said that his dealer was using massive amounts of heroin to override the Buvidal, and he was quite perplexed as to why he was on depot buprenorphine, and was obviously really disappointed when it didn't feel like a long-lasting hit of heroin. And this finding is related to another major theme in the data, which is the lack of information that participants felt that they were given prior to and during treatment. So many participants described not knowing how they would get off this treatment, what the discontinue process would look like, the side effects that they might experience when they're coming off, and what to do if they didn't like the treatment or if they had adverse side effects. And while none of the participants discontinued depot because they didn't know much about the treatment or what to expect, it was a major contributing factor to their decision to stop. Thinking about this, I am curious to know whether or not, or curious to explore if patients were given information by their clinician and they didn't take it on board for whatever reason, or it didn't feel relevant and so they didn't take it in, or in fact, the clinician simply didn't have a lot of information to give them, or the interaction was quite strained and as a result, not a lot of information was exchanged. But in any case, this does raise concerns about patient consent. If patients don't have a thorough understanding about what the potential risks and benefits of a treatment are, what to expect and what to do if they experience any adverse side effects, then they're unable to make an informed decision as to whether or not this treatment is actually suitable for them. So not all participants who discontinued depot had a poor experience with this treatment. Some found it so successful that they said that they felt cured and no longer needed to stay on it, that they felt back to normal. Nicholas and Neil both said that depot would help them to remain abstinent, and combined with residential rehab, they felt ready to start a life without opioid pharmacotherapy. Neil here says, I've been in and out of detox many, many times. So I built up a bit of a rapport with the doctor and a lot of the staff members there at the rehab centre. I wasn't really keen on it, the depot buprenorphine. And then I said, you know what? I think it might be a good idea just to do it for the interim. I wasn't going to get 1 or 2 or maybe 3 depots. And then I was going pretty well and I got to the rehab centre and I was feeling healthy. And then I decided to discontinue it. He gave me a good buffer zone to be in while I sort of got my nutrition back and a little bit of health and fitness and stuff. And then my mental health got better and I wasn't depressed anymore. Earlier, I mentioned the experiences of Andrew, who was forced to choose between having his mental health or opioid dependence treated. And in the interview, he said that while he had a negative experience with depot buprenorphine, it also led him to discontinue all OAT because he felt like he no longer needed it. He said that if he ever felt like he had cravings again, he would start back on sublingual buprenorphine. He wasn't keen on going on to depot. But he currently manages his mental health and substance use with cannabis, which he finds really successful. So a lot of participants found out depot buprenorphine through their clinic or their GP. And while many of these interactions were quite positive, some felt like they were coerced or forced into the program. A number of participants spoke about how depot was the only treatment offer they were offered. And if they didn't want to start the program, then they were on their own. There was nothing else for them. Methadone was old hat. We don't do that anymore. Sublingual buprenorphine and Suboxone, you can go on that. But depot, this is the first line of treatment now, and this is the best. And so this is what you should go on. Others described how the doctor simply decided that depot was in their best interests and started them on the treatment without even consulting them. A few participants like Beth here even felt that doctors and clinicians must have been getting a financial incentive to enroll as many people as possible into the depot program after being pushed by her doctor to start the treatment. She says, my GP was a bit pushy. Like, he really wanted me to try this because it was new and blah, blah, blah. He was just like, you know, this is the new way. You don't want to be on methadone forever, blah, blah, blah. This is something new. I think it will fit your lifestyle very well. You're going well. I don't know if they get a kickoff, a payment for putting people on it. I don't know if there's some sort of benefit for them, the doctors, like pharmaceutical-wise, or I don't know. But he sort of verbaled me. Like, if I really didn't want to do it, I wouldn't have done it, but he was very convincing. So putting all of this together and really peeling back the layers of what the participants were talking about, there were 3 core interconnected themes that emerged from the data. One was the pursuit of well-being, the other was agency and bodily autonomy, and the other was doctor-patient power relations. So participants frequently spoke about the imbalance of power that they face when engaging with their healthcare team. Their clinicians would assert their authority by restricting or withholding treatment options, would make decisions on behalf of the participant irrespective of the participant's treatment goals, and would dismiss a participant's experiences or desires because it did not align with their professional opinion or treatment recommendations. This led many participants to feel like their sense of agency and bodily autonomy had been curtailed. So by making health-related decisions on the participants' behalf or reducing their treatment options to an ultimatum, depot buprenorphine or nothing, participants had their sense of agency stripped away, and any complaint or concern that they had was minimized, and an alternative set of treatment goals were imposed upon them, all under the guise that it was in their best interests. This is not to say that all participants struggle to find equal footing with their clinician and feel a sense of autonomy. Many had a positive experience and a relationship with their regular healthcare professional and felt empowered in their health-related decision-making. Ultimately, participants were just trying to find ways of pursuing well-being, and their clinicians were attempting to help them achieve this. Well-being for participants was feeling at home in their body, being able to comfortably manage their substance use, whether this was total abstinence, being able to comfortably manage having a sense of agency over their health and body, and effectively tend to any health conditions. Sometimes the pursuit of well-being took the form of staying on depot buprenorphine. Other times it was deciding to move on to a different type of OAT. Occasionally it looked like using drugs or discontinuing OAT altogether. And power relations played a significant role in this too. When a participant's way of pursuing well-being did not accord with their clinician's belief, a host of tensions arose, which left the participant feeling neglected and robbed of agency. So I've spoken a lot about issues and have made it sound like clinicians aren't the best people here and that a lot of people struggled, and this is not the case. A lot of my participants, as I said before, had really positive experiences, found their clinicians really supportive, encouraging. If they didn't feel like it was working for them, a lot of them said, okay, how can I work with you? What would suit you best? What would be the best fit for you at the moment? And let's try and work together to find ways of supporting you in the best way possible. But looking at the participants who had discontinued, these are the clinical implications that really came out. So first and foremost, participants were being faced with healthcare workers not being able to provide them with adequate information about the treatment, the discontinuation process, and what to expect from the treatment. They simply said, I don't know. So clinicians and other healthcare workers should and need to have greater access to information about depot and how it works to ensure patients are making an informed decision about this treatment. I recently looked at the state guidelines, clinical prescription guidelines for each state, and interestingly, some of them were quite scant on details about this. So perhaps this is one of the reasons why some clinicians and healthcare workers said, I don't know. The number of participants who described feeling forced onto depot or being told that it was the only option if they wanted treatment suggests that many are seeing this as first-line treatment rather than another tool in the box of things that we can offer people who are after ways to manage their opioid use, reduce it, or to pursue abstinence. So more in-depth conversations need to be had between clinicians and patients so that people seeking treatment can find the treatment path that's best suited to them, their needs, and their treatment goals. Greater attention also needs to be paid to participants' complaints about the side effects of depot buprenorphine. It was quite concerning the amount of participants who were told the issues or complications that arose shortly after starting this treatment were unrelated because there was no pharmacological basis. Therefore, it must be something else. And these participants were saying, I can feel that this is connected and you're not listening to me. I don't feel heard. So we need to be empowering patients in this context rather than dismissing them. And the lack of information that clinicians and healthcare workers seem to have around depot buprenorphine seems to be connected to this as well. The intersection of chronic pain and depot also needs further investigation. There is a suggestion that some clinicians are prescribing depot buprenorphine for chronic pain, which I think is really fascinating. And while these participants only made up a really small portion of the sample, those that were given depot as treatment for chronic pain or had chronic pain conditions that were being treated alongside their opioid dependence, they face a unique set of hurdles, which range from being relatively minor to deeply problematic. And there's no research on this intersection yet. There's quite a lot of research on using buprenorphine to treat chronic pain, but depot buprenorphine, there doesn't seem to be any at this point in time. And based on the participants' experiences, there is suggestion that this could be a widespread issue. And that's my presentation for now.
Well, please stay around, Simon, because we've certainly had some questions and some, good comments come through as well, which we'd like to, I guess, continue on with. And feel free, we've got a good amount of time that you've left us to be able to spend some time on those or anything else that comes through. But first of all, if it's okay for me to say a couple of things, I really like this is awesome because I really like this sort of research, and kudos to yourself and the research team who pick up that baton to try and to do the research on people who don't stay in treatments, because that's usually the harder edge of things, all of that chasing that needs to go on. So it's not often done for that reason. But also, this sort of research really slows things down because understandably, can be a lot of arm waving around these types of treatments when they come in, because the hard data is great, and yes, there is a lot of huge amount of kind of benefits that come from these things, but there's always going to be those other sides. So I really appreciate the very respectful way that you brought the voice of people's experience and the voice of the clients. Not only through this research, but just how you presented that as well. And I'll certainly get on to people's questions, but I just have to say, good job on a visual feast. So that added a whole nother layer to things, which we won't go into now, but acknowledging that, and I'm sure others as well. So some of the questions that have come through. So the 50-50 split of the cohort wanting to continue and not continue, is that typical of the population?
There were certainly a lot more people on the treatment who planned to stay on the treatment when I was going through the screening process. And that one of our concerns going into it was, how are we going to get the people who have discontinued? And this was actually one of the limitations of this study, because we recruited through alcohol and drug clinics and other community-based organizations. These were people who were still in touch with the healthcare system in some way. And while there was a little bit of snowball sampling, most of these participants found out through a clinician in some way. So the people who stopped and then never went back, we didn't hear their voice. And similarly with people who lived in remote areas, while I do see the appeal, and I think it's a really valid one, that it does make it easier for people who live further out, the people who did live further out also said, the one pharmacy in town, he started it, but he had no idea what to do. So I was the one that was teaching him how to do it. And there was a doctor from Adelaide who would come up once a month, and he would be able to do it. But this is a problem for me. I really like this treatment and I want to stay on it, but I just don't have the services here. So yeah, I mean, there certainly was a lot more people who were on it and seemed to be content to stay on it. But yeah, yes, I hope that answers the question.
If there's any follow-up to that at all from the questioner, feel free to pop that in the chat. I think there's a lot of narratives you've tapped into today, and that one just there about the inequitable access to treatment across kind of the population centers of our country. There's another one that shows up that, in these types of kind of investigations and explorations as well. So thank you for that. A great comment here from Jim, and I think Jim's just pointing out, and I think that was around the experiences of people finding that they weren't being held on their initial kind of transfer over to the long-acting injectable products, that short-term sublingual kind of, I guess, top-ups in a way. I'm a psychologist, so feel free, any medical people, to jump in and correct me on my comments. I believe that does happen in our clinics here. And again, I've not been directly involved in the clinics, certainly worked alongside of them, and I do believe that that can be something that is, but again, it's, I guess people need to know that that's maybe an option, that they can, speak to their treating team around that to see if that can be provided.
Yeah, and this was another interesting point, was some people were offered that and it was an option, but other people went in and the clinicians they weren't given that option and they didn't know that it was an option. And that's what some found quite difficult, that there was this uncertainty, and when they weren't offered sublingual Suboxone or sublingual bupe, because the clinician, I got the impressions that clinicians were scared of overdosing the person on bupe if they did this, because it was in their system and they didn't know how much depot was in their system, and so they didn't want to overload the person. And so I think they were trying to play it safe. But yeah, certainly some were given that option and it worked really well for them, while they tried to work out what dosage of depot worked well for them. But yeah, I got the impression that that conversation needed to happen a little bit more.
Sure, definitely. Thank you for that. Also here, we've also got from some of our friends up in Cairns, just an acknowledgement that there's often some of those similar experiences that they have with people who have been on longer term prescription of benzodiazepines for different conditions. So I think that was a comment more, not necessarily a question in that, but again, just follow up in the chat if there's anything that we're missing there. A shout out here for a piece of research that's come through. Have you, or I guess this is a bit of a flag for everyone here who might be interested in exploring this topic more, the South Australian team, the DASA team down there, DASA Pharmacy Project from Eve Allen, that published a report in 2021 evaluating DASA client perspectives on the buprenorphine injection. So that's quite interesting and relates to this topic and your project as well. Are you familiar with that one at all?
No, I'm not. If you could send that through to me, that would be greatly appreciated. I would love that.
Sure. It's in the chat there, but I'll certainly, we'll pop that in, or Niall will just pop that to you, and for everyone else as well. We might just send it out. We might just repeat that post from yeah, that's very helpful. Thank you for sending that.
Yeah, thank you so much.
Yeah. From shout out there to Ruella, who's asked this question. Dulma, nice to see you again. What's been your experience with Indigenous clients? Was that sort of identified? I know that the sample size was in that kind of 40s, and then the actual group that you're talking about. So I'm not sure if there was much kind of ability to explore that, but even anecdotally or
yeah, there was a small group of Indigenous people, and during the course of the interview, they did mention their indigeneity, but it never seemed to intersect with their treatment experience. One person from Canberra did say that they used to go to the Indigenous Health Centre to receive treatment. And at first they found that quite helpful, but then the clinicians, a lot of them were from India and didn't have familiarity with like Indigenous issues and like Indigenous health and stuff. And so she found that really frustrating and ended up not going there anymore. But yeah, I would be interested to do more research in that field. And I also looked at gender, if there was a difference between women's experiences and men's experiences. And there didn't like nothing major came up. In saying that, it wasn't a focus. I didn't ask any questions specifically on ethnicity, indigeneity, or gender. But typically, if it is a major issue, it often comes up in the interview organically, and that didn't happen. So yeah, potentially worth exploring that further, but yeah, it didn't. Issues around indigeneity didn't come up in the interviews, aside from that one person from Canberra.
No, that's really good. And I imagine this is the critical mass of this type of research that's building. So it's, as you said, there's not been a lot of it. Although we maybe found out another one, and I've just popped that into the chat out to everyone, just the name of that report. So I don't, if anyone has that link to the DASA report for the person who posted that, or if anyone else is kind of aware of it or got their hands of it, or if our team here, if they could search for that, that would be awesome. We'll make sure that we share it with everybody. So just that question, I guess it came up around where you were talking about the experience of somebody having their GP. You know, it was a sort of if or then type, you know, for prescribing. It's a question around if youth is believed to interact poorly with benzos, are other medications from your experience, or was there kind of qualitative information that other medications were discontinued if clients wanted to go on to the long-acting injectables? So, for example, antidepressants or antipsychotics. Did that?
This was really interesting because a lot of the participants were on oh my God, the name's just escaped me. Pedigablin.
Gabapentin. So
that's the one.
Yeah.
And some were told, you absolutely cannot go on both of these at the same time. This is really dangerous. Others were on it, and some were on quite a high dose and were on buprenorphine, and doctors seemed fine with it. And same with benzos. Some were fine with them taking both. Others said, this is really dangerous and you're at risk of an overdose. One participant had been on, I think, what was it? She was taking methadone and I think benzos, and she moved from Victoria to South Australia. And when she got to the clinic there, they said, you absolutely cannot be on methadone and this medication at the same time. It's incredibly dangerous. And she said, I've been on this for years. And they said, no, we're going to change you onto Depo. And she was like, I don't want to do this. And they said, no, it's in your best interest. And then she had a bad time. But in terms of antipsychotics and antidepressants, there were a couple of people on that or who had been on it at some point while being on Depo, and they seemed to be fine. But in saying that, like, those people also did, some of them had their mental health exacerbated or declined while they're on Depo. And so there was that complication as well, and trying to find that balance. Yeah. Definitely.
And I guess that's a lot of also the sector learning about these things as well. Of what is okay and what's not. So a couple of other questions that have come through, and we've got 5 minutes, so I hope we'll get through as much as we can. If you're happy to stay around, Simon, and
sure.
So if anybody else is there to hang around for another 5 minutes, that'd be awesome. So I'm just making sure I don't miss anything here. So does any research suggest that clients that take buprenorphine exchange their drug use for methamphetamine? I'm not sure if that was the focus of your study at all, but did anything kind of come up that was?
Yeah, so a lot of the cohort had experience with meth dependency or were using meth regularly prior to going on to depot treatment. And a lot of them said, when I started depot, my meth use actually went down. The rest of my substance use went down. And so it's been really helpful for that. I've been able to like cut down and become abstinent for everything. And there was one participant who said that he had a couple of friends been prescribed depot for meth dependency. And he was a bit baffled about this because he's like, you only get it for heroin. I don't know why you get it for meth. But I was talking to a colleague and yeah, apparently it's a thing. Apparently some clinicians prescribe it for meth dependency. But yeah, there was a lot of multi-drug use within the cohort, but there didn't seem to be when the opioid went down, other drug use went up. That didn't seem to be the case. It seemed to be the opposite.
Oh, okay. No, that's again, small size and all that sort of power comes into that. However, it's interesting because it's coming straight from sort of the clients themselves to hear that. That's really good to know. Okay, and just a couple of other, and thank you, Ruth, for posting the link to that study. Obviously available through the PubMed database. So thank you very much for that. And just going down a few more questions there is, okay, so this is, again, probably looking at a specific sort of situation, but it may, sorry, my chat just moved when the screen moved then. Sorry, I just have a, when we shifted views, I lost my spot there. Let me just come back. It was a question, it looks like it was about a specific situation where a client wants to enter detox. Oh, okay. But does not want any OAT. We've all got different initials for that, but I'm assuming what we're talking about there is the agonist treatment. Sorry, antagonist treatment. So for many of the reasons you mentioned, tried before, felt pressured, dislikes, side effects, etc. Definitely trying to promote this person's agency, bodily autonomy, but facing barriers with detoxes, having to require OAT prior to entering as part of risk management. And if I've got that right, because I'm aware of this myself, that some of the residential programs now, with the introduction of the long-acting injectables, some residential rehabilitation programs are now taking people who are on the opioid dependence treatments, but they are specifying or, kind of saying that needs to be the LAIs, often more due to logistics. Yeah. So yeah, lots of little narratives and discussions that could be opened up again around that. Any recommendations on how to approach? He is in fact being incredibly open to exploring from months of ongoing conversations, but can't help feel it's going against his autonomy.
Yeah, it wasn't until recently that I had seen a recommendation that depot can be used as a withdrawal treatment. So giving people a weekly dose so that they withdraw and then can enter into rehab. Yeah, completely abstinent. But I'm not sure.
No,
yeah, sorry.
The positive side here is now that is a treatment modality that's open for people who maybe wish to remain on maintenance type therapies. And because it's not always, some centers or agencies have policies where people can remain on the long-acting injectable whilst they're in the inpatient treatment or the residential rehabilitation treatment. And it's quite varied. There's no consistent landscape around that. So good on you for to the poster of the question there for trying to balance sometimes when we intersect with systems that often work in different ways or have different requirements that don't allow us. So no easy answer to that one.
Yeah, and I mean, another area where that cropped up was in relation to prison.
Yes.
I had a lot of people who had either come out of prison and started depot, had been in prison and started depot there, or I think had been on depot prior to going into prison and then had to stop because it wasn't on offer. And this was really interesting, and I think warrants further investigation, because I think it's only in New South Wales that depot is offered in prison. And people seem to really like that because it prevented like violence in relation to like people wouldn't be stealing their methadone or their bupe strips. And so it appealed in that way, and it was just, they felt like it was better. And people who had been on it seemed to really like it and then struggled to continue it after they came out. And so like in relation, and some people went into prison to detox and just loved prison as a result. They were like, I got clean, I thought it was great, and now I feel fantastic. Certainly wasn't a common narrative, but it was a narrative. But
that's
yeah.
Good. We've got time for one or two more questions, and just to shout out as well, it's certainly available in Queensland prisons.
Oh, okay, sure.
Injectables. The project's been going since about sort of 2018, 2019, and is being adopted in different kind of jurisdictions in different ways, but it's certainly heading down that path. But I do like your report, which also one of the findings was, hopefully there's any policy makers out there, starting to sort of that stuff that's easy sort of done with a stroke of the pen, that it must be this or it must be that. Hopefully there's some pause for thought around the sorts of things here, because we know that preference in treatment is such a big factor for efficacy and outcomes. So just probably one other question we've got time for. So I do apologise if we haven't got to everyone. There's a mention there about the Withdrawal hotline, if anyone's got that number, that obviously that's an option that people can be made aware of as in terms of clients to get advice. So, and there's a mention, there's the DASA long-acting buprenorphine project is in the process of peer review at the moment. Happy to be contacted to share project experience. That's from the project author, Eve Allen. Thank you very much for being generous. I hope everyone's seen that post in the chat. Welcome and thanks for sharing.
Thank you so much.
Yeah, that's great. Were there any consumers? This might be our last question. I'll scan through the others and see if I can hit anything that's really quick to go through. Were any consumers discontinued due to did they say they discontinued due to any restrictive prescribing practices? For example, not being allowed 3 weekly dosing or not exceeding 128 milligrams. I suppose probably the question there, the core of that question, I think, is did anyone say that the prescribing practices were too restrictive? That was a reason why they discontinued.
As in, like they weren't being able to be given enough?
Or I'm assuming here, again, this is always when we're working off chat functions, 3 weekly dosing. I'm imagining that's if, say, if a clinic had a strict, it's got to be 28 days or for, you know, that kind of window side of things and not allowing a bit of tolerance or flexibility around either side of that. Again, that is an assumption I'm making. So I do apologize if I've misinterpreted that at all.
Yeah, and this is what I was kind of talking about earlier with clinicians being a bit unsure what to do when clients coming in saying, this is running out early, I need something because I'm not in a good place. Some were happy to give the next weekly injection a few days early and just top up that way. Others were given sublingual bup as a top up until the clinicians, until like the dose like officially ran out. But yeah, like that sense of hitting this wall with clinicians saying, I can't give you any more. Yeah, you can either just write it out or or take this. But there did seem to be a lot of uncertainty around the best course of action and what the best form of treatment would be in that situation. So yeah, again, like I think, because it is so recent, like we're still testing the waters around what works, what's best for people, but also like just the lack of research available to clinicians and people around this, because in a lot of the state-based clinical prescribing reports, there are so many instances that says, there's no research in this area. And so here's what we think should happen, but like there's just no clinical information.
Sure. Look, that's fantastic. Now, I do apologize. We've taken more of your time, and I know everybody else usually is dedicated the hour and probably has things backed up already to get to. So we might need to end the question and answer to Simon at this point. So I do apologize if we haven't got to anything. Just a couple of matters. There's been thank you for everyone who's been so generously sharing their knowledge about resources and things. So the Withdrawal hotline number's been popped in there by Susan for anyone who was asking about that. The link to that study before was a study done in Switzerland, and as Eve Allen has pointed out, theirs is in peer review and will be available because this is a great again, massive evidence to be starting to build to help us be able to inform and maybe start to answer some of those questions. And there's lots of them, but it's really good that you're building that base that can continue.